Okay, so today well, welcome everybody who are here and who are not here. We're going to talk about organ donation updates. There are a few things that are, I think, relevant, uh, you know, regarding donation that you need to be aware of. So why does organ donation matter? Well, we have 103,000 men, women, and children who are on the national transplant waiting list. They're waiting for an organ. 17 people die each day waiting for an organ transplant. Every donor can save 8 lives and enhance over 75 more with tissue and eye donation. There is 46,000 plus transplants were performed in 2023. Now, some specifics here. Most of the patients who are waiting on the waiting list for organ, they are waiting for a kidney, right? Like 89,000 people. That's a vast majority of people waiting for kidneys, and then liver following like 9,000 people, pancreas 800, kidney and pancreas together like 2,000 people waiting. For heart, there's 3,400 people waiting on the list right now. Lungs, almost 900. And transplant performed per organ in 2023. Kidneys, well, there were 27,000 transplant performed. So that's basically maybe one third, right, of the need, which is like almost 90,000 people on the list waiting for the kidneys. Liver, there were 10,000 liver transplanted, and pancreas 100, and then hearts there were 4,500 heart transplanted. So think about it like, obviously there's always a scarce organs, right? There's not available, and we're barely catching up with the needs. Like every year, right? There's a big gap, and that gap is not easy to get to, right? And this graph will show that how, there's a huge part on the top patient on the waiting list, and the transplants received were like, that in pink zone, and then the blue zone, living and deceased donors. Um, so you can see like how huge is that gap. We're trying to get that gap lower, right? And you can see like after 2013, things are getting a little better to decrease that gap, but still there's an area that we need to catch up. You're probably aware of these triggers that we need to follow when we have somebody, on ventilator. Um, so making the call within 2 hours of meeting the triggers, patient should be intubated or trached, right? And either they have one or more of these clinical triggers, GCS 5 or less, due to a condition or an illness, loss of two or more brainstem reflexes, transfer of ventilated patient to another hospital. That's ones that we usually miss, especially coming from another hospital to the ED, and nobody gets, you know, told that. Starting TTM or beginning the discussion of comfort care or goals of care, withdrawal of care with the family. And that's something also like we've been missing. So most of our missed referrals or like timely referral, you know, uh, I would say like limitations are mostly in the medical ICU because mainly the patients are here, right? I mean, it's not, so like it really touches this unit the most. So if you start talking to the family about it, like you're writing your note, possible withdrawal of care, that's actually a trigger to call Finger Lakes, um, you know, about the patient. They don't necessarily have to have an answer, but it's like to be abiding by the laws. These days the laws that we have to follow are the Department of Health and the DNB. So actually, we are required by the law to actually call for the trigger, and before you withdraw care, before you remove the breathing tube, we have to call Finger Lakes and get an okay, that they don't need that patient for a donation. So they have to reach out to the family, and then they get the consent, or not, but they have to discuss it with the family before we can withdraw care. Now, there are some certain times that you cannot wait too much, or they take forever to answer back. finger legs. In those cases, yes, obviously, we can go ahead and proceed, right? But these are like, few times, but we have to abide by that, rule. And the reason is like, because if we don't do these, only like less than 2% of people die in a way that, can possibly become a donation. Only 2% of deaths. So it's very scarce already, right? And then if they're in the hospital, so why not use the opportunity to the max? And that's why they are making it, you know, more obligatory in that case. Here, RT, sometimes they have to remember to ask the nurses, like, hey, did you call Finger Lakes? I would like also the medical ICU team to think about it. Just a little thought, before you withdraw care on somebody, to make sure that the nurses, like called Finger Lakes, just check that box that was done, because we get dinged for that. Like there is no like punishment per se, but when it comes to compliance, that's something that the DNV and the DOH they look at when they do their meetings.
How many roughly misses have you had recently?
So, I mean, I had the numbers. I don't have them right now.
Is it like dozens a year, or is it?
Yes, there's more than 12 like a year. So missed referral, like they were never called. But timely referral, like the percentage that we're looking at to be timely is like, 70%, 80%. We were like at 50 sometimes. Some months like 40% timeliness. Just to be like calling within the 2 hours trigger, you know. But missed referrals per se, almost like a dozen a year, um, and that's like up and down, but we should not have any missed referral. Like, nobody should die without having at least a call, you know, to Finger Lakes. Yeah, some people even like die and then they never get a call about after death even, so that's even weird, because usually the compliance there is like more like 95 and above percent when people die to call within 1 hour. You have to call within 1 hour after death, to tell me that the patient died, because actually at that time they can reach out to the family for tissue, you know, and they have up to 24 hours to recover those tissues after death. Okay, so that's that. And never pre-mention, right? Like, don't talk to the family about organ donation as a possibility, because that's becomes like more like a conflict of interest. Like, we are, as an ICU team, we are just treating the patient. We don't have any, we should not provide any conflict in that meaning. So some families refuse organ donation because it was brought up early on, and it's something that also we're not supposed to do. Now, there's two kind of major donation that happen: DCDs, and which is donation after a circulatory death, and there's a donation after brain death. Now, for circulatory death, right? So basically, the donors, the consented donors, after consent is obtained, and the reason they had devastating neurological injury, or they can have like a very bad terminal disease that they cannot really survive, but they do not meet the criteria for brain death. So we do intentional withdrawal of life support, and that's what we call cardiac arrest, right? So until there's a circulatory death, there's a 5 minute no touch period. So after the patient dies, there's no circulation. You wait 5 minutes just extra in case there's something called auto resuscitation. Well, in the history, there have been patients where they would go flat and then they come back, but that's less than, like, it's very, very rare, and usually happen in the first minute or two. So they said, you know what, we're gonna wait more. And some places they don't wait 5 minutes, they wait 3 minutes, and which is still adequate. And again, the patient consented for donation before the withdrawal of care, either them or their family members. Think about them, like if they're awake by the terminal lung disease and they know they're going to die without the ventilators. So that's also one of those DCDs. Now, either they recover the abdominal organs after death, they go to the OR and they recover those organs, or they take the lungs. And that's from the current practice, right? Now, I'm going to go back into more details in the DCD, but in the meantime, in 2024, there were 7,200 DCD donors like that, like from withdrawal of care. And that's actually increased by 23%. So DCD is becoming more and more frequent than brain death donations. And So that's a big increase. In 2022, 4,700 people donated after DCD, and that's a 14% increase from 2021. So it's going up, you know, in a good pattern. Now, DCD donors have increased in recent years, as we mentioned, providing more organs for transplant. In 2024, there were 9,700 donors who encountered brain death. And that number is becoming less, so that's less than 2023. So our brain death donations, they might be increasing, but not at the same rate increase as the DCDs. In one study, 1 year survival after a DCD recipients was 92% versus 90% for brain death donor recipients. So they are, close by, right, in terms of like survival. So that's how like they are as important as those donations after brain death. So there's something new that is happening in terms of DCD. I don't know if you guys heard about NRP. So NRP is normothermic regional perfusion. It's a new procedure to restore circulation of oxygenated blood via cardiopulmonary bypass following the declaration of circulatory death. So after you withdraw care, let's say in the procedure room or in the OR downstairs, instead of we wait for 5 minutes and then the patient goes to the OR to recover their organs. So that time that the patient actually died and you declared them dead, that time is called ischemic time. So it takes them maybe like, I don't know, 15 minutes, 10, 15 minutes or 20 minutes to recover those organs. They're going to be very ischemic. And then they usually take the kidneys. They have up to 120 minutes after death. Like, for example, after you stop the withdrawal, like after you stop care, right? After you withdraw care, you can wait up to 120 minutes until there's a flat line to say that you can go ahead and continue. So the kidneys can survive ischemia for up to 2 hours, but the liver only survives half an hour of ischemia. So usually the transplant team come for the liver, they wait half an hour. The patient did not die in 30 minutes, and the pressure was being like low forever. Like there's no like real like yet circulation. Like it didn't stop yet. So then they will just leave because like that liver is not good anymore. So that's are usually like the DCD times, and that's why like when you withdraw care in the in the procedure room in the OR, you might stay for 5 minutes. The patient dies, or like up to an hour. Usually we don't have to wait that much. For 2 hours. Usually like that's when they probably like left already. The transplantee is like, okay, these organs are not gonna be beneficial anymore. So this procedure comes into play to prevent that ischemic time. So basically, most of the organs, in addition to the heart, are eligible for donation in this technique. And basically, you're putting those organs on ECMO. So after you perfuse as abdominal and thoracic organs of the deceased patient. It does not resuscitate the patient, right? So you're just perfusing those organs. So they can take a look at them and they can prevent that ischemia time from being, high. You can see like in the picture, like 30 minutes after, cardiac arrest on the left, that's how the liver and the intestines look like. But then 30 minutes after cardiac arrest plus 30 minutes of NRP, like, they put them on the bypass, look how pink they look now, and now they can actually evaluate, take their time, to see if these organs are actually worth, they are, like, are they like good enough for transplant? And so there's a chance to correct metabolic abnormalities following circulatory arrest. Insight to assessment of organ function prior to the transplantation. And you reperfuse multiple organs this time. You can reperfuse the heart, the lungs, intestines, kidney, and liver. So sometimes when we only looked at kidneys and a liver within half an hour, that's it. With DCDs, now you can do more organs with DCDs. So it actually expands the number of organs that you can actually recover and transplant. It limits the warm ischemic time, which leads to better patient outcomes because you have less ischemia. That means that the organ is going to be better for the recipient. Higher number of transplant for less acute patients, and helps expand the donor pool, as we mentioned, shorter length of stay, etc. So that's the benefit of NRP. NRP has been used to help recover DCD hearts in addition to the abdominal organ. So, once you put the patient on bypass, the heart will beat again. And that heart can be assessed closely and can be recovered from transplantation. While DCD without NRP donation has increased the number of abdominal organs and lungs pool, it has not been able to increase the number of heart transplants. So DCD alone, we did not really increase the heart transplant, but NRP allowed us to increase that number by 15 to 30%. So you can increase the heart transplants by that much. So you increase it by 30. And that's going up with more organization or more like hospitals doing this NRP. So there's a few things about thoracic NRP. So when you call thoracic NRP is, so again, let's be more specific, right? So the patient for NRP, usually they withdraw care in the OR, not in a procedure room. So they are in the operating room. There is a drape. The drape covers, basically the head down, and you withdraw care as usual. There is no change of the withdrawal of care process because, again, our job is to do the process exactly the same. We don't make it faster. We don't make it slower. We do it exactly as we do it every day. That's why there is no certain way of withdrawing care. It's like what you think the patient is comfortable. Like, what's the most comfortable way of the patient dying? That's how you do it. So after the patient, like, you withdraw care, there is family there sometimes, you need to support the family. That's part of the ICU job also, to support the family. Maybe not you as a physician, maybe as a nurses, but, that's something important to mention. So after the patient dies, we wait for 5 minutes, no touch, and that's when they're already like draped, ready to go. They start cannulating. Depending what kind of NRP they do, it could be either thoracic or abdominal NRP, right? So if it's thoracic NRP, what they do is they actually cannulate the aortic arch and they cannulate the venous, IVC, the femoral, and they put the patient on bypass. But there is an issue there, right? Because once you cannulate the heart, some blood flow can go to the brain. And then what happens if you have blood flow to the brain? Then the patient will be alive again. So that's brought up some ethical issues with thoracic NRP. First, you have your heart, probably when you put it on bypass, it's going to start beating again. So if you are not a believer of circulatory death, like, oh, the heart is beating, but, and there's a blood flow, that's actually against the rule of the patient has to be dead for donation. Like, that's one of the main rules of donation. It's called dead donor rule. So because NRP involves reestablishing circulation in a deceased donor, it is very important to ensure that there is no blood flow reaches the brain to comply with that dead donor rule. So what do? They clamp the carotid arteries, to make sure there's no blood flow goes to the brain. Now, because we know if there's no blood flow going to the brain, that's considered death, at least brain death. But again, there's an ethical dilemma there that they say, okay, but you are causing it to happen, right? And what about the beating heart? Is that like, you're bringing the patient back to life? So that's still in process. There's a lot of organization that they're still hesitant to go and do heart NRP, like thoracic NRP, that can actually recover the lungs as well in that process, lungs and heart. But mainly is the heart the one, the tricky one. And some people said like, oh, there's some vertebral circulation that you don't stop when you clamp the carotid arteries. So there's some backflow. Now, on the other hand, the transplant surgeons, they did a beautiful article with a lot of patients, and they did the transcranial Dopplers, and they did like a nuclear scan for these patients that they clamped the carotid and there was no blood flow. So there is no like, so they took away that part where like, oh, maybe there's a flow from the posterior circulation, but you know, like they had like evidence that it actually stops completely the flow in the brain by the nuclear scan that they did. So they studied that, and they said like, okay, the patients already consented to donate their organs. It's not like you're going there to make them survive again. I mean, they wanted to withdraw care, right? They wanted to die, and they died, and then you declared them dead, for 5 minutes, and you already signed the death certificate, at that moment. Patient is dead, and they consented for it, and then the whole purpose is to help recipients get, organs and give a life to others, right? And that's the whole purpose of donation. And that's the comment that came up into the discussion and this ethical dilemma. But again, I want you to know that that's happening, and some places they actually monitor the patient to confirm there's absence of brain blood flow, like measuring the intracranial pressure using near infrared spectroscopy. You can put like those transcranial, like almost like a pulse oximetry. You can actually put some on the head, and you can see if there's any blood flow there, in addition to securing the vascular clamp is on. Now that part is called thoracic NRP, and it did help increase the heart transplanted. So if you think about it, like, for people who are waiting on the heart waiting list, heart transplant waiting list, it's actually very helpful. It allows the surgeon to evaluate that beating heart, for a couple of hours in the OR, 3 hours. They can check lactates for the liver. They can, check the liver. They can check the kidneys, see if the kidneys start making urine again. They look at the liver, make sure like it's getting blood flow again. So it actually, check the lactate a few times, and then they can, be more tempted to get those organs and recover them without being ischemic organs. Well, where do they do them, right? So a lot of places they do them, like NYU and in Rochester they do it, California, Mayo Clinic in Jacksonville, Florida, Yale, Connecticut, Northwell in New York. So there's multiple places are doing them. So this is not like only here, and that they want to expand it because there's a big need for, transplants. It's a huge need for transplant. A lot of people are waiting, and then it gives them another chance of life. So that's about the DCD. Now in the abdominal NRP, right? So we talk about thoracic. For abdominal NRP, think about the clamping of the aorta. It happens at the descending aorta. So they clamp at the descending aorta, and then they cannulate there. So basically, you're perfusing only the abdominal organs in abdominal NRP. So in that case, I don't think there's a dilemma, right? Because you don't perfuse the heart, you don't perfuse the brain, like it's not supposedly to happen. You're just perfusing those organs, basically putting those organs on ECMO, And we approved that here at St. Joe's. So we're doing abdominal NRP, and we did one case. And that case would not have been able to donate the liver, probably plus minus the kidneys without that NRP, like, without NRP, because like the patient, could have died later on, or the transplant surgeon would not really agree to come to wait for the patient, like to be ischemic for a long time. So actually it allows it to recover that liver, and it was transplanted successfully. Of that notice, in December, in the CVICU, the 3 people received transplants. Somebody received the liver and both kidneys, as well as the pancreas for research. And there was like a lot of cornea, skin, nerve, blood vessels, bone, and soft tissue was also received as well from that single donation. Gave a liver and the 2 kidneys, and the pancreas was sent for research. So that's some of the outcomes, recently. I like to mention them because we take care of them, but we don't know what happens with these patients. Another patient in January of 2025, the patient had the there's a grateful recipient through the recovery and transplant of the left kidney. So they also got one kidney transplanted, and that's from the medical ICU. And another one in January. We have 2 donations in January of this year. There is 2 recipients from the recovery and transplant of the liver and the right kidney. Now, the left kidney was also recovered, but was not able to be transplanted. Also, the patient was a tissue and an eye donor. And this patient specifically, the one that happened in mid-January, that was our first abdominal NRP case. And this really, Dr. Ali, you were on the case. Yeah. You and Dr. Emery, were on that case. And then without that NRP and facilitating that, this patient could not have, donate his liver. Okay, so that's that. Now, I don't know if you guys are aware of this article. This is the updates to the brain death criteria. It happened in October of 2023. It would be great to review it because it's been a while. This is like from 2010, there was no new guidelines for brain death. So there is a lot of recommendations, like a lot of recommendations, like a huge article talking about pediatric and adult brain death criteria. And there are some few changes I'm going to mention just to keep you, up to speed. And these are changes that we made to our brain death policy here at St. Joe's from the guidelines. They changed the word irreversible cessation of like a brain function to permanent. Like when you, because like that's one of the definition of brain death. So you have to have a permanent cessation of brain function. They removed EEGs and SSEPs as an ancillary testing. So you cannot use EEG to say the patient is brain death or like to as an ancillary test, right? Usually we do ancillary test when you do the physical exam, you do the apnea test, and the patient, you cannot declare them using those 2 methods because there are some confounders. Either they have a lot of drugs in their system, or their acid base is not great, or you cannot do an apnea test because the patient is not stable, hemodynamically. There's a lot of pressors. Then once you stop the ventilator, they're gonna just die. So you cannot do that apnea test, etc. And that's where, or like for example, you are on ECMO, although there is some ECMO guidelines that were added by this article as well, with specific blood pressure parameters and apnea testing procedure for ECMO patients. So that's also something that we can do. Because this procedure is a little bit complicated, though it's doable, and we should try to do it. It's always good to do the ancillary testing of nuclear blood flow scan, like as a confirmation. The brain death is not something you want to be on the gray zone. Either the patient is brain dead or not. You cannot be like, oh, maybe brain dead. It's like, no. So that's why like it's not, like it's something that you don't take lightly. You have to be very sure the patient is brain dead. For infants now, they have to wait 48 hours before examining or before starting the brain death exam. In the past, I think it was like less than that. It's like 24 hours. Now, also for adults, you have to wait at least 24 hours after the injury, after the acute brain injury, and after the cardiac arrest to actually start testing. Like if you see the pupils dilated, all the signs of brain death, you don't do the testing before 24 hours of an injury. At least that's the recommendation. Also, they changed the MAP pre-requirements for testing above 75 and not above 65. And they also increased the systolic blood pressure, but mainly the MAP, right? Remember, like it has to be above 65. You use Levofed to get it there before you start the brain death protocol. So now they want it above 75. And it's a little higher on ECMO patients. So we added the NRP definition in our DCD policy. Sometimes they require us to order heparin for the patient, the unit for the clamp time. Usually it's 30,000 heparin. It could be higher if the patient is, requires it. And they usually also order 4 units of blood on call for the procedure. You cannot really order blood for a patient who is dead. So after you withdraw care and the patient died, you cannot really order blood for them, So ideally, you want to order the blood, and they actually communicate with us, tell us like, hey, can you order this and that for the procedure? And the last case, only 1 unit of blood, I think, was needed. So it's not like they always need blood for the procedure. Good communication between everybody. It's very important to update your most forms when you declare somebody brain dead or you're going for a DCD. These patients who are, DCDs, no, actually, like the patient who are brain dead, right, and they're waiting to go to the OR. They usually, like, there should be a good communication between us and the OPO in terms of the CPR part. Like, is the patient DNR or not? What if the patient arrests when they are consented for donation? They arrest and they didn't go to the OR yet. So that's a discussion that have to do with the OPO and with the family. It's like, hey, if the heart stops, we still have to do CPR to save the organs for donation. So that's an important discussion. Sometimes we don't mention. Some nurses were hesitant to do CPR for these patients, and we had like issues in the past. So this is all communication that has to be fluid, and everybody should be aware of what's the plan is. The code status is very important. Yes, yes, they can say no, but then the finger legs can try, to talk to them about it. But again, it has to be discussed. And sometimes remember, like first person authorizes people who are registered donors, they have a say in donation, right? So the family legally cannot change that selection of the patient. In the past, they were able to. It was an intent. Now it's a consent. So when you register to become a donor, like on your license or whatever, you are a registered donor. That's a consent. That means like if something happens, the family cannot change that, you know. But and that's why like it's important for the family to talk to each other before they get to the hospital, or get sick enough for donation. Um, but that's something that to keep an eye on. That's the other thing is like when somebody dies, either you withdraw care or the patient is brain dead, please do the death certificate on a timely manner. Like it's very hard to close the charts, without that death certificate and the discharge navigation thing done in Epic, either here or in the OR. When the patient is declared dead in the OR, also you need to sign that death certificate. Um, uh, Withdrawal of care happens in the OR, as we mentioned. We had in our NRP case, the family got out of the OR after the patient, they saw the patient. There was like a drama, crying around. The whole OR heard it. There is no nurses to find to support that family member because the nurses brought it from the ICU and they left. They had maybe one nurse, but like she was busy with the OR stuff. But then again, it's something to keep an eye on. Just need to give support for that family, um, for the whole process. There is no change again in how we provide comfort to patient. That's not gonna change. Do everything as always, right? Still, there's a 5 minutes no touch time just to make sure the patient is dead. Um, I want to bring one last thing in terms of our policy. This is our policy of St. Joe's, right? So I am gonna read it. Procurement of organs cannot begin until the patient meets the cardiopulmonary criteria for death. Pronouncement of death is completed and documented in Epic by the attending physician. At St. Joseph Health, there will be a waiting period of 5 minutes to confirm the loss of and monitor for the return of pulse and or respiration prior to pronouncement of death. Now, the absence of heart function shall be determined by the lack of a palpable pulse in a large artery like carotid, femoral, or brachial artery, in combination with electrocardiographic changes consistent with absent heart function. Like what? Like if the patient is in VFib, electrical asystole, pulseless electrical activity, or electromechanical dissociation, right? So you don't have to wait for the flat line. So you don't need asystole to declare somebody circulatory death. Like this is, basically you're stopping, like the circulation is stopped, but you don't have to have zero electrical activity. In our last case, there was a little delay, in that case, waiting for that asystole. There was like maybe 5 more minutes added to the 5 minutes initial. So that was a concern that they had. And the recommendation is that if there's no pulse, and that electrical activity is not really meaningful, then, you can still declare the patient death as a cardiac death, right? So it is highly recommended to have an A line in these cases. So any patient who have a DCD, most of the time they are here, right? In the ICU, they have an A line already, but it's really recommended to put an arterial line and use it when you go to the OR. So why not just use it? Like maybe you cannot palpate the radial, maybe you cannot palpate the neck, pulse. If you're not sure, how about you look at the A line, look at it before you extubate somebody or before you withdraw care and see how that lines, get flat, right? If it's flat line, at least, you're not going to palpate the pulse. So that's a way that you can confirm. And if you're hesitant about any activity on the EKG, right? But again, the whole point of circulatory death is there is no circulation. There is no like meaningful perfusion of the patient brain and organs. And this is an article in 2023, and it's the American Society of Transplant Surgeons recommendation on the best practices in donation after circulatory death organ procurement. So they have a lot of recommendation regarding before and after, all that stuff, to ensure that the patient have like, so they can get like the best transplant outcomes. That's it. Questions, concerns? Thank you, everybody.